Hey there, I am Jesus Guzman from Kaiser University, and I will be presenting to you a case study on the right clavicle that I performed. My patient was a 50-year-old male. Once I call my patient, I will introduce myself. I'll say, "Good afternoon, my name is Jesus Guzman, and I will be taking your x rays today." Communicating with the patient is very important. So I will ask my patient his date of birth, reason of visit, if he's in any pain, and if he had any recent surgeries. In order to confirm that I have the right patient, that I will be performing all the exams he came for, that I do not cause any more pain than what he has, and allowing me to be aware if I find any artifacts in the radiographic images. My communication before, during, and after with the patient will go just like this. Before the procedure, as I'm walking him to the x ray room, I will ask him questions. I will then explain the procedure to him so that he has an understanding of how things work. I will make sure he does not have any extra clothing or accessories on the area of interest so that it will not obstruct the anatomy. During the procedure, I will instruct him how to be positioned and I will tell him to remain still so that I don't have to repeat the procedure and keep exposing him. After the procedure, I will inform him that his doctor will be receiving the results in 5 business days, and from there, he will get the results. Throughout the whole time I'm with my patient, I must make sure that my communication is clear, that I use basic terms, and if they do not understand English or have any issue on hearing, then I'll use my body language to help them visualize what I want them to do. The primary diagnosis for my patient was that the posterior displaced fracture of the sternal end of the right clavicle sequela. Sequela meaning a condition from a previous disease or injury. So here where my cursor is at is where the sternal end is at, or in another case, the head of the clavicle. And here in the superior view, it will be located right here. And for the inferior view, the sternal end will be located right there. The chief of complaint of my patient was that he had pain and that his range of motion was short on his right arm. So that gave us the classification of the soft tissue of the right acromioclavicular joints, right here. National Center for Biotechnology Information studied for 11 years analyzing clavicle fractures. 535 cases were uncommon, and they used the ALMED system, the image to your right, to take note of the fractures. 2.6 of all fractures were from clavicle fractures and 44% in the shoulder girdle, so around the lateral third. 68% were from men, 61% was in the left arm, 81% middle third of the clavicle, that is most common, right there. The medial third is the least common with 2%. Most cases are caused by car accidents and athletes who play sports such as football, rugby, basketball, or those who compete in boxing, karate, CrossFit, or weightlifting. The patient history was that he fell down and applied pressure on his right arm trying to stop the impact, but instead he injured himself, causing him to have pain on his right shoulder. The patient did have surgery. He stated that they inserted a large metallic staple at the head of the right clavicle. After the surgery, the pain continued on his shoulder, so he informed his doctor so that he can get an appointment for an x-ray. For this procedure, the routine will be an AP and AP axial. The SID will be 40 inches and you will use an IR of 10 by 12 inches, landscape wise. However, since my clinical site did not have a 10 by 12 inch IR, I used a 14 by 17 inch IR and collimated enough so that the entire clavicle is demonstrated, from the SC joint to the AC joint. For the analog, you will use 70 plus 5 kV and the digital 80 plus 5 kV. You will always shield the patient, but you do not want to shield the area of interest. The position of the patient will be by having their arms on their side, chin elevated enough to not obstruct the anatomy, the patient looking forward, shoulders relaxed and against the IR. For respiration, you want to make sure that the suspend respiration at the end of inhalation so that it can help elevate the clavicle's anatomy. You want to make sure you collimate enough so that the entire clavicle, SC joint, and AC joint is demonstrated. For the AP projection, you want to make sure that the CR is perpendicular to the mid-clavicle. The entire clavicle is demonstrated, showing the SC joint, AC joint, and acromion. For the position, no foreshortening of the clavicle. Mid-clavicle is superimposed on the superior scapular angle. Exposure, the mid-clavicle sternal-acromial extremities are clear. Sharp bony trabecular markings and soft tissues are detailed. Here, in the bottom right corner, is the radiographic image of the patient. As you can see, here is a metal staple that was inserted on the head of the clavicle. And here gave us assumptions of some fracture that could be happening in the patient's acromial clavicular joints. For the AP axial, the CR will be 15 to 30 degree cephalad to mid-clavicle. Since my patient was hypersthenic, I angled my tube 15 degrees cephalad. The entire clavicle is demonstrated, showing the SC joint, AC joint, and acromion. The clavicle will be above the scapula and third rib. The medial portion of the clavicle will be superimposing first and second rib. For exposure, no excessive brightness on the distal clavicle and AC joints. No motion on bony margins and trabecular markings. The SC joint and medial clavicle demonstrated through the thorax. The purpose for the procedure was to find any signs of fractures or any pathologies that may be causing the patient to have pain. After reviewing the X-ray images, the staple inserted on the head of the clavicle was visible and there was no sign of fractures or pathologies. Here we have the report. So the indication was that the posterior displaced fracture of sternal end of right clavicle sequela. From comparison of the right shoulder from 5/18/2020. Technique used was an APN angled views of the right clavicle. The findings were a large metallic staple or bracket transfix at the head of the right clavicle. There is no indication of an acute fracture. The cortical margins are intact. There is now a well corticated 5 mm calcification in the soft tissues medially on the superior aspect of the AC joint. On review, this was faintly present on the prior right shoulder study of 5/18/2020. There is no distortion to the AC joint. For the impression, there is no acute fracture deformity. Prior ORIF, open reduction and internal fixation of the head of the right clavicle. There is a non-specific well corticated 5 mm calcification the soft tissues medially in the superior aspect of the AC joints. Unfortunately, for this patient, there was no fracture or pathology present. However, if there were to be a fracture or pathology, some suggestions that may come to mind could be tendonitis or myositis ossification. Tendonitis is an inflammation of the AC joint that causes pain on top of the shoulder. Some of the symptoms are swelling, pain, and irritation. The diagnosis for the tendonitis will be an X-ray to show injuries of the bones or an MRI to demonstrate soft tissues. Some treatments will be anti-inflammatory drugs, surgery, or physical therapy. So on the top right corner, you can see an AC joint injury and the separation of the joint from the acromion. And in the bottom right corner, you can see a normal clavicle. Myositis ossification is a bone tissue that forms inside the muscle or other soft tissue after an injury. Some of the symptoms are warmth, swelling, bumps, decreased range of motion. The diagnosis for this pathology will be an X-ray, but it will be difficult to find abnormalities. Ultrasound can use sound waves to scan the tissue, but it is not recommended for the first test. CT can be used to see development of the bone tissue in the soft tissues, but MRI is the best method for looking at soft tissue growth. Some of the treatments for this pathology can be to rest, icing the area, elevating the affected area, using elastic bandages to wrap around the area to reduce the swelling. And here you can see on the top right corner the myositis ossification. And in the bottom, of course, is the normal clavicle. Here is just the references that I used. Although my patient did have pain on his shoulder, there were no signs of fractures or pathologies on his clavicle. That concludes my presentation on the case study. Thank you for watching.